All right, we're going to get started. Thanks everyone for joining us this evening. Tonight's lecture will be given by Dr. Andrew Starr. Dr. Starr is one of our hip and knee replacement surgeons at Rothman Orthopaedics. He sees patients in our Chalfont, Willow Grove, and Doylestown offices. And tonight he will be speaking on robots and joint replacement. Where does it fit? Just a reminder, if you do have any questions throughout the presentation, to please enter them at the Q&A box at the bottom of your screen, and we will try to get those questions answered at the end of the lecture. Dr. Starr, you can take it from here.
Oh, well, thanks very much, Natalie. It's a pleasure to be here as always. It's really fun to talk about something that I'm so excited about in orthopedics. So I'm Dr. Andrew Starr. I'm an orthopedic surgeon. I've been with what's now Abington Jefferson for 35 years. I'm an associate professor at Jefferson and teach a lot of residents and fellows. So I do get a lot of opportunity to talk about robotics and technology and kind of where it fits. So let me just do some computer things and share my screen, and then we'll go ahead and start the actual presentation. So be right with you in 1 second. Let me just do a couple of technical things. Okay, I'm just going to maximize this here and make sure that everyone can see this. So Natalie, can we see the screen now?
Yes, good to go.
Okay, great. So thank you very much once again. So my topic tonight is an interesting one for me, and that's robotics and joint replacement. Where does it fit in? Where does this fit for doctors? Where does this fit for patients? And if you're a prospective patient or you have a family member or somebody that's contemplating a joint replacement, this is certainly something that, may be of interest to you. So, but without any further ado, these are my disclaimers that what I'm talking about today, even though I work for the Rothman Institute and I work with Jefferson, these are really my own opinions and they're information. And obviously, if you need medical advice, you shouldn't rely upon something you hear in a talk. You should go see your doctor and get their advice. I also have some disclosures. I do work with two companies that have relationships in the robotic world, one of which deals with computer navigation in hips, and the other deals with robotics in knees. So those are things that you always should know if someone's telling you about this and what their biases are. And I will admit to having a lot of biases because I generally am one of those people who likes technology and thinks that technology can help us in our day-to-day life in many ways. I also like to put this additional information up there as we're starting, which is that there's no clinical photographs in this presentation. Everything you see will be a drawing. There's no blood. There's nothing like that you need to be concerned about, that you might think, oh my God, I don't know that I'm ready to look at this. So this will all be plastic. So without any further ado, where do we stand in 2000? And this is from 2022, this article, but where do we stand at the beginning of 2023 on where robotics fits in with joint replacement? And I wanted to start with this. I've given this talk in similar fashion before, and I always like to start out with what's the latest article on this. And this is an article that was published in a well-known journal in Europe. And what it says is that robotic technology, robotic total knee replacements, have been found to have improved accuracy and better patient-reported outcomes. That means that patients say that they're doing better with a robotic knee replacement than a regular knee replacement. And, it's easy to say that, and you have to be careful of claims that you see, even in print and from reasonable sources, because when you actually look at the detail of this, and that's what we do, in academics, we look at how these things are developed and what the outcomes are and how they're reported. If you look at this article, which talks about this, all of the things that they reviewed, all of the outcomes, all of the data that they got from patients really were slightly better with the robot. But they even said in their conclusions that they didn't feel that it made enough of a difference to really change how a patient would feel. So just because a patient feels that or writes down on a survey that they're feeling like they're a 6, whereas another patient says that they're feeling like they're a 5 out of 10 in terms of how their knee feels, unless you get a lot of patients to say that, and unless there's a big difference, it doesn't necessarily change overall how the patients feel. The other thing is most of these studies measured outcomes in patients several months after surgery. There's no follow-up, years later that would really tell you how these are doing in the long run. The one thing we've seen consistently, and I'll show you some other information, is that the X-ray pictures look better. When we look at the X-rays, when we use any kind of computer systems for our patients, when we're doing surgery, they're more accurate. They look better. The computerized input definitely makes things look better. Does that translate into a better patient outcome? Not necessarily. Now, if you look at this, you'd say to yourself, well, so Dr. Starr doesn't think robotics is a good idea. Well, if that's the case, why do I do virtually every replacement in this day and age with a robot or a computer? And it's because I really do believe in the technology. It doesn't mean to say that it's proven yet, and nobody should really tell you that it is, but I do believe in the technology and I believe it is the future. And look, there's a lot of things that we've talked about over the years in joint replacement, minimally invasive knee replacements and hip replacements came out in 2000 roughly and have been around for 22 years. If you do a Google search at one particular day when I did this, I had over 8 million hits when I put in the term minimally invasive knee replacement. Robotic knee replacement gets 6 million hits, and muscle sparing joint surgery gets 1.3 million hits. And if you look at the data on all of these things, even though people make tremendous claims about them, there's still never been a clear-cut proof that these really make a difference. Once again, do I like them as a surgeon? Are there reasons that I do them? And I do everything on this page, but I don't really look at a patient and say, because you went to a surgeon who didn't do this, that in this time, 2023, that we can definitely say that they're doing a worse job. So remember when you go on the internet, and I love the internet. I'm one of those surgeons who patients come into my office and they say, wow, I've been on the internet and you probably don't like it, but I saw this and I saw that. And I really like it because I think it is a good jumping off point. And it shows that the patients are serious about their condition and they want to participate in getting better, which as a surgeon is extremely important. So what I always say about the internet is you're going to bring me information. You're going to tell me things that you've learned about on the internet, but it's not always education. It's not always 100% truth, but it does provide a good place to start. So that's where we are. So that's 2023. Let's dive into the details here a little bit. So the causes of knee and hip pain are numerous. Trauma, meaning a fracture, systemic diseases, people with rheumatoid arthritis, people who inherit abnormalities in their bone or their cartilage, and just the normal overuse. I played too much tennis. I've got a sore shins from doing that. Those can cause pain in the joints. But what we're really talking about today is osteoarthritis, which is one of the most common and one of the most disabling causes of knee and hip problems in this country today. So obviously arthritis is a big deal. And why is that? Well, people are living longer. They expect to have a more active lifestyle, and they do. Unfortunately, they also put higher demands on their joints, not just because they're exercising, but obesity in this day and age is a big problem for us. There was just something on the news today about it and showing that once again, the growth of our obese population every year has continued. So that does create problems for people with their knees and hips and does lead to arthritis. And if you get arthritis and become inactive and then become heavy, it's that much worse. So what is arthritis? Well, the arthritis I'm talking about is the growing old arthritis, the osteoarthritis. And everybody gets arthritis if they live long enough. And basically what happens is if you look on the pictures on the right, the middle picture where I have my arrow here, hopefully you can see it, is a normal knee with a space in between, and that's where the cartilage lives. The picture just to the right of that is an arthritic knee, which we describe as bone on bone. And you can see there's no space left. And also the bone is turning white. That bone gets really hard like marble. It's hard as a rock. And what you see if you open up the knee is this is a knee on the left, and you see the white cartilage in many areas has been worn away. So it's kind of like your tires on your car. You lose the tread and you no longer have the padding that you need to function normally. So this is typical of arthritis in any joint. There are different types, but this is the standard wear and tear arthritis. And I'm in my 60s and, have some areas of arthritis from playing sports for years. And, the most common treatment for arthritis, if you think about it, is not really surgery. The most common treatment for arthritis are things you do in your house, like your heating pad, or just taking it easy, putting your legs up, using ice, using anti-inflammatories or Tylenol. So we're going to focus as an example on knees today. Why did I choose knees? Well, knee replacements are the number one joint procedure done with robots today. We do partial knees as well as total hips with robots in orthopedics, but the numbers aren't nearly as high. And spine certainly is a tremendous area of growth in robotics. And that would be a different talk by another surgeon within orthopedics or neurosurgery who could tell you about the role of spine robotics. But it is something that we do an awful lot through the Jefferson Health System, and something maybe worth researching if you're considering spine surgery. So our knee replacements, what do they look like? Well, knee replacements came out in the 60s in this country, and they've looked fairly similar throughout that entire time. Most every knee replacement has a metal top and bottom, and that gets attached to the bone. I'll show you what that looks like. And it has plastic in between. So what we want to try to do is put this in a patient to put that padding back in between, which is the plastic, and the metal attaches to the bone. And that's what a knee replacement is. And that's what they've always been and probably will continue to be for a long time. So here's not a clinical photo. Remember, I said to you that these would all be plastic. So this is a plastic model. We have these in our office. And this shows on the top, there's a metal piece that's adhered to the bone, either glued or the bone grows into it. There's two ways. And there's a metal piece that attaches to the bottom bone, and the plastic in between serves as that cartilage. So if you look on the right here in a well-performed knee replacement, we've put that space back. That bone on bone is gone. So when you lose the bone on bone, hopefully the patient feels better. So why consider using a robot or any other advanced technology when you're considering a joint replacement? And I mean this from the standpoint of the patient or the surgeon. Well, if you're walking through the desert and everything's great and it's a beautiful day with the sun coming up, you wouldn't think you should change anything. But if a sandstorm comes up, you might look at trying to get inside and not continuing your walk. Well, we know from multiple articles that we've produced ourselves as well as in other places that there's a fairly significant number of patients who have knee replacements in particular. Hips are a little more successful, and they don't get better to the extent that they would like. They may get better, but they don't get to that extent. And if you look at the articles, and if you very rigorously look at this, somewhere between 80, 85, some articles say 90% of knee replacement patients are very happy. Well, that's looking on the bright side, glass half full, but it certainly means that there's a percentage of patients that are not happy. And we do see those patients, and we'd like to perform a better knee replacement. And we think maybe if we can do these better, we won't have as many patients that are dissatisfied. So we've been doing knee replacements for the last 50 years in a very similar fashion. The joints haven't changed that much. There's been slight alterations in terms of size and fit. Many of you have heard of joint replacements for women or different sizes. Certainly, women knees, I think, are a little less popular. It's more a question of having sizes that can fit anybody, because a lot of factors affect what type of knee you might want, your size, your ethnicity, how the knee's damaged, how much bone needs to be restored. So we need many different kinds of knee replacements and many different sizes. But fundamentally, we've always put them in by using some form of a ruler and making measurements and basically fitting it to the joint by hand. And you see that for one particular company, this is a very common, we call these jigs, and it has basically a caliper type of arrangement. You squeeze the bone in between this is plastic again, but you squeeze the bone between the metal bottom and the metal top, and it tells you this person needs a size 5. And we measure it, and then we fit everything together. There's a number of different jigs like this. In this particular one, it allows us to measure the angle that we want to put the knee in. And this is what we use. We use a saw and we just cut through the slots once we get this all situated. And that allows the knee to be put in accurately. But it's a very much of a hand type of process. And then at the end, you glue the knee in. In this case, you see the white glue and it fits together, and then you have a good knee. This is another example of something that we use. Here's a video of us using it on a model. We put this device on there and we can line it up and make all kinds of adjustments of angles, and then we take a saw and cut through that. So that's what we do. So robotics, can this help us in this process? And clearly the answer is it can help us with putting a knee in more accurately. That's been proven. So robotics may be helpful. But when you pick something new, and I always urge caution, I trained with Dr. Rothman years ago. Unfortunately, he's no longer with us. But one of the things he always said to me was, don't change anything until you're sure that something you're going to change is going to be better. And, don't always be the first one to jump into the newest technology. Although truthfully, I think there are technologies that it's been worthwhile to jump into on the early stages. But I always tell my patients, you can have what we've always been doing, and that'll have known outcomes, but may not be as good as you'd really like. So you get that 80, 85, 90% success rate. Then you have new technology, which you hope's better, but it could be worse. And in some cases, it may turn out to be a very bad idea. And we've seen that. And, you just have to look at the internet to see the number of law firms that are talking about implants that are no good. And the truth is, it's really a very small percentage, but there have been some mistakes. But we can't make progress unless we try something new. And I think that that's a very important part of understanding how we make decisions. But, and this is, I think, the key, we need to emphasize what's important. A lot of times, patients and doctors pick things because in the case of the doctors, it's kind of a fun idea. Using a robot, or patient wants to have a robotic knee, it sounds better. Lasers are similar. Are lasers really better in certain circumstances? Maybe, but they don't bring much to the table for joint replacements. Is it satisfying to go through it? Is it satisfying for the surgeon and the staff who use the device and find that they can put it in more accurately? But if it doesn't change anything substantial, then it's probably not worth it. And that's the standard that we need to look at. We need to look at important things like patient satisfaction. Is the patient happier after this knee replacement? Do they get better faster? We've seen several procedures where the patients have had improved outcomes. The general surgeons use robots and they can do minimally invasive surgery in a way that the patients can be out of the hospital and doing things much more quickly. Implant longevity, that means how long it lasts. Can we take a knee that might last 20 or 25 years and have it last 30 or 35 years because we put it in better? Well, that's what we have to prove. Today, I can't tell you that robots can do that. I'm hopeful. I'm slightly optimistic. I'm excited about it, but I can't tell you for sure. And, once again, many of you may have heard of the metal on metal hip, which was probably one of the worst things that was done in joint replacements. Most joint replacement ideas have been very good, but these have led to, certain contamination of the bloodstream with metal ions and some potentially bad outcomes for our patients. So, we have to be very thoughtful as we do this and also very honest with our patients about what we can provide. So what is our goal? So as we talk about for a robotic surgery and for a joint replacement surgery in general, what's the goal? Is it just that we need to be more accurate in placing the joint? The answer is that's part of it. But the second point here is very important. If you talk to 10 joint surgeons, you'll get different ideas about how the joint should fit, how they should be aligned, how straight they should be, how the ligaments should be positioned, what size the joint should be. Most of our high-tech devices make better cuts. They allow us to be more accurate, but so far they don't change how the patient feels, and they have cost more. And until we can agree upon this middle thing, just having a device that gets us to put it in more accurately may not be enough. But certainly, and this is very interesting, this is a paper that was published in 2018 in the Journal of Arthroplasty. This is one of our best journals in joint replacement, and it's read by most prominent joint replacement surgeons. And what you can see is across the board, looking at all the different insurances and looking at the bigger and smaller hospitals, virtually everybody is spending more money and putting in more, utilizing more technology progressively over 10 years. And we only have up to 2016 in this article, which was published in 2018, but this trend has continued. So we know that technology is something we want to have, we believe in it, but we need to make sure it's the right thing. So we need to decide what we want and where we ought to go from here. So first of all, to talk about this, navigation was the predecessor to robotics. And you can say, what do you mean by navigation? Is that like when I get in my boat and I have to figure out where I'm going? Well, in some respects it is in terms of a joint replacement. So navigation started, we started doing it in 2005. And this is what a navigation apparatus looks like. And the reason I'm showing you this is because this is the basis of robotics. So this has a camera, and this camera can see these reflected balls. Once again, this is just a drawing that are attached to the patient's extremity, and it can convert that into what the leg looks like on a computer screen. So the key function here is have an optical device that interfaces with the leg to allow the surgeon to have a computerized representation of that joint and then allow him or her to do something with it. And even when this came out in the mid 2000s, we learned very quickly that we could do things much more accurately. Now, it takes a little longer, it costs a little more, at least by this technology. And it so far has not shown much else other than you can put the joints in more accurately, which seems to make sense, but so far hasn't been proven to change the outcomes. And here's a paper looking at the entire country of New Zealand over 12 years where this was very popular. Excuse me. And they showed basically no difference in the outcomes with a total joint replacement done by navigation. The only thing they saw was it took longer and it cost a little bit more. So when we weren't quite there in 2005, what is a robot? Is it better? Well, a robot is a navigation device. It builds upon navigation, but it also allows you to actually do the surgery. So it has an implementation device, most commonly a robotically controlled cutting device, whether a saw or a burr or something like that. Now it's under the total control of the surgeon, but it does go a step further, and I'll show you more specifically what that means. So does the robot do the surgery and leave the surgeon to do nothing? And I think it's very important that we dispel this rumor. And I'll show you how the robot works. It is not a robot like you've seen in science fiction movies. It is a device that assists us, but it's not a robot like you think. So this is one of the simpler robots. Now this cart, I don't have a lot of pictures of this, but this cart actually has that camera and the computer, but this attaches to the knee. This is a saw held by the surgeon, and this simply has a slot that can be moved with a computer device using the screen to make the cuts to fit the knee on, the knee replacement implant onto the knee. I'll show you more about that. This is the most common. These are two very common computers and robots, the two most common today. They both have robotic controlled saws. Now I'll show you later. It still has the camera, the computer interface, but now what the difference is instead of just moving a slot or trying to eyeball it, once you do the computer calculations, you make your calculations, you tell the computer where you want things to be cut or altered to prepare for the joint replacement, and the robot actually moves the saw into position. The surgeon then takes it and makes the cut under the control of the robotic alignment. You can move it all around, but the robot keeps you aligned. So that's a typical type of a robot, either a slot or a computer controlled saw. So what's available today? If you go to the Ace Hardware store and you go to buy a robot, what can you get for a knee replacement? Well, here's a few of them. This is one of the ones I showed you just now that has the robotic controlled saw. And I want to emphasize every one of these has the camera and the computer screens. And you notice you can see the knee on the screen. And I'll show you more about that in some videos. This is a similar device. In this case, it moves the slot with the robotic arm, doesn't move the actual saw, and then you cut through the slot. Very similar technologies. This is an interesting one. Instead of a saw, it has a burr that's under the control of the computer. Similar kind of device, camera, computer, same here, robotic controlled saw, camera, computer. So you can use a saw, you can use a cutting burr, and it allows the surgeon, by looking at the screen, you can see the screen quite readily here. I'll show you a bigger version of this, showing the knee, and we're designing, custom designing the fit of this implant to fit the knee. This is the most interesting one, which really doesn't get used very much. This is an autonomous robot. So all the other robots, this is the first one I showed you with the robot controlled slot. All of the robots, the surgeon operates. In this case, the surgeon still operates it, but once they put the information into the screen, they move this device into the area of the patient's knee, push a button, and the robot takes over, and the surgeon literally just sort of sits there and watches it, and the robot actually moves the tip around. It's kind of like the engineers do now when they prototype devices, where they design it on a screen, and then there's a fancy machine that actually machines a piece of metal or a piece of plastic into that shape. This is not used very much. It's not popular in this country, and I don't know when we're going to see that. The other devices are what's becoming popular, at least here. They've been trying to get this under the name of RoboDoc. It was bought out and has a new catchy name, RoboDoc, has a new name, but it's similar to what has been used for years in Europe. But once again, not very many cases out there. So a robotic procedure, it has steps. You have to learn how to do it. So without going through the detail here, let's look at some of the steps. So the first thing you do when you use a robot is you have to tell that camera where the knee is. So what you do is and I'll show you this in a video, you turn the unit on, and then it shows you a model like this, and you have to touch all these points on the bone, and then the robot creates a model in the computer that matches that bone. So this is what that looks like. So it's a multi-step process. It'll just take about 2 minutes for this video. So the first thing we do is we move the hip joint around. And what this does is it tells the robot where the center of the hip is. Now we're going to show the robot where the center of the ankle is. So once again, plastic model. These are the photo arrays. The cameras would be behind me. This is the saw waiting to be used. And we're going to touch various places on the bone. And this is real time. This is how long it takes. And we're going to go ahead. Now we touch the tibia. That's done. Now we're going to paint the surface of the femur. That'll take another minute or so. And then we will have a model of exactly the shape of that bone. And then as a surgeon, I can adjust that to make the knee fit exactly how I want it to be in a very accurate way. So we are almost to the end of this, believe it or not. and this will be completely registered. And, time for this is just a couple of minutes. So I'll let you watch this for a second because we are getting to the end of it. And we're going to just paint a couple more spots on the top. And now we're going to confirm that we've made the pictures, and we're going to confirm that where the picture is, you see the green light in the background there. That tells you that the model matches what we're touching in the robot. So let's go on from there. Then we get a screen that looks like this, and this is a ligament balancing screen. So now, if you notice, we can see on the left-hand side the knee in many planes, and it actually starts to position the implant around the knee. So you can actually see the metal implant on the surface of the bone where we're suggesting to put the piece. And then we can look on the right-hand screen here at the tensions in the ligaments, which we've measured. And we can actually, with this robot, not only match the bone, but also match the sizes and shape of the ligaments to make this knee what we call balanced. So that's what we do. And this will show you a little bit of how we make those adjustments. Okay, so I showed you this part already. So I'm going to move up here. And you can see now you have the surgeon in this case using a touch screen. It's a sterile touch screen we use in the operating room. And in this case, he's adjusting the thicknesses of those cuts and literally moving that implant around. And as he does it, on the right-hand side here, we see the change in the numbers that reflect the spacing of the ligaments. And then once we are happy with it, we say, okay, let's bring in the robot. The robot puts us in position. And here, like I said, the surgeon always does the cutting. The robot never does it for you. The robot can't even turn on the saw. But what it does is it helps the surgeon to stay exactly where they planned for them to do this robotic surgery. So that's what that looks like. And then ultimately, we put the pieces in, and that's what the surgeon's doing here. So now we've made our cuts, and this is a plastic model of a knee implant, and we can take it through the range of motion, and we can demonstrate on the computer and watch as he moves this. The robot will show the movement of the knee and will give you a demonstration. In this case, 3 millimeters and 4.5 millimeters is how much the ligaments are moving as we go through the procedure. And if we like that, we say, okay. If we don't like it, we can change the numbers and recut with the robot and do it very accurately. Okay, so that is a robotic knee replacement. Basically, instead of using the rulers and the jigs that I showed you before, there are no rulers and jigs in this procedure. You're simply using a computerized navigation system, and then the implementation tip, whether it's a slot, a saw, or a drill, and you're machining that knee to be very accurate. So far, we know we're more accurate. That's been well proven. We can make better pictures. Everything lines up better. But how do the patients really feel? And we have currently robotic options for hip, knee, and partial knee replacements. And that's what we need to continue to figure out. So as we get to the question and answer section here, after going through this in some detail, I want to sort of finish with these thoughts. As of right now, there are many technologies. It's like cell phones, it's like televisions. You have a lot of options for what you can choose as a surgeon or a patient. There isn't a lot of agreement about the best way. However, my feeling is we need to develop these things. We know the existing technology, we know the problems, and we know we need to be better for our patients. If we do upwards of 1 million knee replacements in this country and probably 600,000 hip replacements in this country, that's a lot of people, even if it's 5 or 10% that are unhappy, that we would like to make better. So that's really the motivation. So what's my secret? What would I tell you, whisper in your ear about robotic technology if we were sitting together and we could do this in one room? Well, we're still studying this. We're trying to achieve the best results. There have been some favorable reports, things like costs declining as the robots are being manufactured in larger numbers. The time it takes to do these procedures are being streamlined as new robots are being developed. We're developing improved accuracy. There's still a cost issue. We need to be cost effective. We still don't know for sure who should be using this, whether a patient should choose it or a doctor should choose it. We recently submitted a paper on what patients' perceptions were of robotics. And, that's going to hopefully be published in the near future. But we certainly are seeing that some patients really think it's a great idea. Not too many patients, ironically, felt that they wanted to have to pay anything extra for the additional technology. But they are interested in it. Although there still are a lot of people, and I really am gratified by this, who say that the surgeon probably makes more of a difference than the particular technology that's chosen. So I do like it. I do think it's the future. We've been committed to it for many years. Navigation for over 15 years, over 10 years of robotics, starting with partial knee replacements, going to total knees and hips, publishing studies as we go amongst many other well-known surgeons and surgical groups. And so we're very happy to be able to be a part of this, but we just want to be very clear and very honest that although many of us think it is probably the future, we want to make sure that patients understand what the implications are of trying new technology and being involved in this. Having said this, I've done myself almost 1,500 robotic knee replacements. So it's not like it's something new, but we are getting better at it. And I do think it's ultimately going to be a better thing. If you have a great surgeon who has done your other knee replacement and you say, well, now should I go get a robotic knee from somebody else? I would say to you, have confidence in this person who's done this for many years. The most important thing is a master surgeon. These other things will help everybody else and even the master surgeons ultimately to be better. But the fundamental thing is that the surgeon and their team and your cooperation and participation is, of course, the most important thing. So with that, I don't want to over talk this up. I want to make sure that we have time for questions and we can migrate immediately to the questions. So let me stop sharing my screen. And I think Natalie has a couple questions she wants to start with, and then we can go to the Q&As as well for what you've sent in.
Yes, absolutely. So a couple people did email me ahead of time. So the first question for you, Dr. Starr, this woman says, hi, I'm 79 and a candidate for hip replacement as well as both knees. She is 79 years old. Is that too old? She's an active person, tennis player, loves to exercise, 112 pounds and 5'2".
Well, first of all, congratulations on being perfect weight, because we're a heavy society and people with arthritis frequently gain weight because they're not active. So that's fabulous. There is no age for joint replacement. The youngest patient I ever did was 21. The oldest patient I ever did was 98. And they're all unique. Too young is bad because the knees last 20, 25 years, the hips similar. And that's bad because you have to do them over. You can probably only do them a few times. Too old can be a problem if you have a lot of health issues. But I really don't think that you should look at age as the magic. The magic is, how's your health? How much of a commitment are you going to make to getting better? Are you willing to put in the time and the effort? And you need to go see somebody who will explain to you what the process is to make sure it's what you really want. So age is not a barrier. Our average age for a knee replacement or a hip replacement is somewhere 60s to 70. We do a large number of patients in the 50s and the 70s and 80s, somewhat less in the 90s. But, the last time I did someone in the 90s was a week ago. And the last time I did somebody's in the 40s was a week ago. So, for people who do a lot of joint replacements and, teams like Rothman, we do a very large number of patients across all spectrums. And sometimes I have to tell a 60-year-old patient who may have a lot of bad health problems, that they're less of a candidate than someone who's 79. So don't feel that you can't have that, but it has to be for the right reasons in the right situation.
Right, thank you. Next question. Do you perform this type of replacement on bilateral bone-on-bone knee replacements with bone spurs and people that are bow-legged?
Yes. So bilateral joint replacements, knees and hips, are common. They've become somewhat less common as the surgeries ironically become a little simpler, because patients, I think, perceive that they can have surgery, get better fairly quickly. Whereas if you do both at once, it's a little bit more of a production. There's also a somewhat higher risk profile in patients who have two knees or two hips done at once. So once again, this is a patient selection issue. I do double hips and double knees on a regular basis. I did one a couple of hours ago, but it has to be the right patient. Those tend to be our younger, healthier patients in better physical condition, and ones who are willing to put in the time. I keep saying that. Putting in the time to have a replacement is something that you have to commit to, because it's not always an easy thing. Now, there's another question. I want to go to a question that's on that I saw on the chat, because it relates to what you just said. And that's that, what about the bow-legged issue? One person asked, should I get my knees done? What if I only have one done and I have two bow legs? Well, unless if you're extremely bow-legged and your legs are literally unable to function, we would try to do both at once. But in most cases, we're going to make the leg 90%, 85, 90% of the time, we're going to make the leg better. So you'd rather have one good leg and one okay leg, meaning one straighter and one bowed, than having two bowed legs. So yes, you can have one done. And particularly in the elderly, it's very common that if we give them one good leg, they can sort of substitute for the other one. A lot of the younger patients who are much more active, they're going to go ahead and ultimately have the second one done. But that's not much of an impediment. I think you had another one, Natalie.
Yes, one more that came through email. Dr. Starr, I'm a patient of yours and have highly recommended you to all of my friends who I feel need your professionalism, care, support, and attention. Over the last few months, I've experienced tightness in the hip area, like a hard, tight cramp. Is it normal to go through this feeling over the years? It's been 4 years since the replacement.
Well, anything's normal. I mean, obviously, our first question is we need to rule out a problem. So we would have we'd ask a person like that to come in, get x-rays, be examined. Something that people sometimes don't think about, and it's kind of obvious once you hear it, is that people with artificial joints are subject to many of the same problems that we see in patients who don't have artificial joints. So for example, you can get tendonitis, you can get bursitis, inflammatory conditions in the muscles or tendons. You can tear a muscle. There's many other conditions. So the question is, and I strongly suggest that a person who's having symptoms go and see their doctor and say, first question, is this a problem with the joint replacement? Which often it's not. And then the next question is, well, what is it? If I've got tendonitis, maybe I go to the physical therapist and work on those tendons because I'm getting a little older and I want to feel better. So we do, the majority of the patients that come to me asking a question about their joint replacement, even years later, most of the time we're doing simple basic treatments. Physical therapy, anti-inflammatories, strengthening exercises, avoidance of certain activities. So yes, that is something to look into, but it doesn't really raise my great concern. So let me cover a couple of more. Why are robots more common for knees than hips? The application for robots, first of all, knees were done first in a large number, starting with partial knee replacements, where actually is where I started with them. Hips, a lot of the robotic offerings have not really focused on the full surgery. So with the knee, the robot helps you to put in the top and the bottom piece. The initial offerings in the hip really focus mostly on the socket without and then you manually did the ball side. And the thing is, it's a little more cumbersome to do a hip replacement. A lot of the hips have moved in the directions of less invasive and anterior and other things. And that's a whole other conversation, anterior versus posterior in hips. And they're both totally accepted. They may have their pros and cons. But I think that the way the application has rolled out, it's been easier for us and more natural to incorporate in the knees. The hips, I just don't think we're quite there yet, although I use a robotic navigation system for all my hips. So I haven't migrated to the robot. I'm certified in the robot. I've done some, but I really want something that's going to deal with both sides. And those are in the development, and there's some that even say that they can do that, but they haven't been that popular yet. Does Rothman do partial knee replacements? The Rothman Institute has multiple surgeons who do partial knee replacements on a regular basis. I was supposed to do one this week, although the patient ended up getting a cold. But yes, we do them very regularly. It's probably about 5% of knee replacements because you have to have the perfect patient. The patient really needs to have a partial knee replacement means that it's really only in one out of the three sections of the knee joint. And a lot of people get arthritis in more than one section. I was told that my hip would need to be completed first before my knees. So after my hip, how long before my knees can be done? And how long is the stay after each procedure? Well, these are all complicated questions. You don't necessarily have to have a hip done before a knee or vice versa. I've done them both ways. I tend to try to figure out what's bothering the patient the most. The timing in between surgeries, I tend to tell people 3 months to let your blood count come back up, and the chance of a blood clot is higher, but for a few months. But there are surgeons who will do it much more quickly. I just think that if you're not going to do it on the same day, give yourself enough time to get your energy back and be in tip-top condition, because although the complication rates are low from these procedures, you hate to take a person who's relatively healthy and getting around and really just has an arthritis problem, and then they have a complication because maybe you didn't wait a little bit of extra time. Next question. Whoops, the questions are moving. I've gained weight in the last year and a half due to knee pain. Does this inactivity reflect the ligament tension? How do we come up with a happy medium for the tension? I'm not sure what you're asking with that. The gaining of weight obviously happens a lot, and it's a chicken and egg problem. People who gain weight get arthritis. People who get arthritis gain weight. It doesn't really have a huge impact in a way that I would say is predictable on ligament tensioning. It does tend to beat up the joint more just from the force. How do we come up with a happy medium for the tension? I don't know that there's any one answer to that question. Is there a lot of ligament and cartilage juggling during the surgery? There's always that. And that's what I like about the robotic systems, because I do that on a computer and model it on the computer system rather than kind of eyeballing it. Now, like I said, multiple papers show that master surgeons can get this right just as much as robotic surgeons up until now. But I think ultimately it will just be another tool that will allow a master surgeon to become that much better. Is that there yet? I don't know. It's not proven. How soon after a knee replacement can activities be resumed? Golf, gym, swimming? There's actually several papers that ask surgeons this question and say, when do you let patients go back to things? There's no right answer. Some people heal more quickly than other people, and that definitely will affect when the surgeon says you should do it. And some surgeons are more conservative and may say, for example, a lot of our implants, we use porous ingrowth surfaces. That means there's a rough surface that the bone grows into, and you really need to wait. You don't want to stress it too much in order that you loosen that hip or knee before it gets well fixed. So it may depend on how the knee was put in, how the hip was put in, how young or old the patient is, how good the bone is, how quickly they tend to recover. I generally tell patients for the first 6 weeks, I like you to treat yourself like you're healing. So do things like walking, get out, live your life, but recognize that if you overdo, you may pay a price, which in most cases will simply be a much more prolonged time of healing, but it could potentially add to the time or the outcome, and maybe even lead to needing additional surgery. So I think that's a great thing to talk to your surgeon about, but no absolute right answer. I mean, certainly I've had patients come back and tell me that they've gone back to playing golf in 3 weeks, and some of them come back later and say, wow, my knee got really sore after I did that. I probably should have waited longer. So what's the right balance there? I had necrosis at the incision site after my total left hip replacement. Is this a frequent outcome? If I do my right hip, will that be again? Well, necrosis is something, the wounds get stretched. There's a lot of movement, and everybody's wound heals differently. Obviously, people with thinner skin or diabetes or circulation problems have more of a problem with that. In most cases, necrosis just means that the wound edges uh, die back a little bit. And in most cases, it can be just treated with normal wound management, sometimes additional surgery. It's not a super common thing, but it does happen, with the large number of replacements we do. It does happen on a moderately frequent basis. Most cases, it can be treated simply. If you have surgery again, the surgeon, obviously, if they're aware of it, they may be able to take some additional precautions in terms of positioning the wound or how the wound is handled or closed that might be helpful. Does medical insurance like Medicare cover the extra cost of robotic surgery? That's a really interesting question. There isn't a tremendous difference in cost. That's an insurance question. There are some surgeons outside of Pennsylvania that I know of who who don't take insurance, and they do charge extra for these types of things, but it's very insurance dependent. And there are a couple of insurance companies that, because of some of the additional costs of robotics, do not allow their patients to have robotic surgery, or they refuse to pay the extra costs. So it isn't that much of a problem in my practice, but it does happen. Are there common factors for patients that are not satisfied with knee replacements? There are a good number of patients where no specific factor is seen, although there are articles that show that the participation of the patient, as well as the underlying state of mind of the patient, can make a big difference. So we all know people who go into things very optimistic, or people who really want to work hard to get better. And then we know other people who say, I'm just going to try to let this heal by itself, and I don't really feel I need to do anything. It should just heal and get better. And unfortunately, we've shown in papers that that at least there's a tendency for the people that participate more in their care and try to do the right thing all the time to do better. Interesting, for example, people ask about obesity. Obesity has been shown to be associated with more complications. Although, as I like to tell my heavy patients, if we can get you through the surgery without the complications, obese patients actually tend to do fairly well. I'm not saying you shouldn't lose weight, but I think that there's definitely some thought process that if you can have surgery, although we do what's called optimizing. We want to try to make our patients in the best possible condition possible. Does PRP or stem cell injections negate knee replacement? Well, once again, this is that information versus education. So PRP is like a hormonal treatment. You take blood, you spin it down. It stands for platelet-rich plasma. In the doctor's office, you take a certain part of the blood and you inject it back into the knee, and that's supposed to help the cartilage grow. Stem cells are cells that can grow into any tissue. And we know that in the laboratory, we can take a stem cell and make it grow into different kinds of tissues like cartilage or bone or ligament. But to my knowledge, when it comes to joint arthritis, there's no great information, no proof that these patients actually grow the tissues in the way that these additional hormones or additional cells would hope they will. I do think this is the future of orthopedics. I don't know that I'm going to see it in the next 10 or 15 years as I'm around. And I don't know that what the time frame is going to be on this. I would submit to you that since PRP and stem cell injections, as of the recent past, something could have changed today, I wouldn't know. But as of the recent past, are not improved by any insurance company in the United States that I'm aware of. That's on the basis of the fact that there's really precious little proof that these things make a difference in the setting of arthritis and joint arthritis and osteoarthritis in particular. So I tell patients, look, it's your nickel. You do what you want to do. And I could certainly convince a lot of patients to have this, but I've chosen not to do it myself because I just don't think the weight of evidence is there that says that it's a good idea. And I really think that the costs, which are very expensive, it's unfortunate when patients put their hard-earned dollars into these things and they don't get the satisfactory results they would like. Now, remember, you can inject somebody with water, and initially they may convince themselves that their knee or hip feels better. So they always have testimonials where they say, "Hey, somebody got better. Look how well they did." But to as of today, I would say that there's not much force of evidence that would say that you should have that. And if I had arthritis and I needed knee treatment, I wouldn't have either of those treatments. I might try some of the other more approved things, certainly before a joint replacement, but I wouldn't do any of those. Should I exercise before my hip or knee surgery? Absolutely. I'm a believer in pre-therapy. Not every doctor is, but I think that the patients that get going earlier do better. Um, and I think that that's something that may be of value to our patients. Can one ski on a replaced knee? This is the risk reward question, right? So you can ski on it, of course. The question is, what's it going to do? Right. And this was asked in a survey of orthopedic surgeons that I mentioned before, that some surgeons say, sure, go ahead. Some surgeons say no. It's not really the surgeon's decision, it's the patient's decision. The act of skiing itself, I don't personally think is a bad thing for an artificial knee or artificial hip. But you have to recognize that you may have forces applied to the joint in a fall or a collision that may exceed the strength of the bone or the joint and may damage it in a way that would require additional surgery. And if we have to reoperate on your knee under those circumstances, the results are likely to be worse. So I'll give you an example. I had a patient who comes from a foreign country where they do a whole lot of skiing and well known for it. And the patient was an excellent skier, skied basically before they could walk, and said, I'm going to ski on my artificial knee. And the thing I said to him was, look, I don't see a problem with that, but if you're doing jumps or if you're going out there on an icy day up in the Poconos when on a holiday when the slopes are crowded and you're more likely to be injured, I don't think that makes sense. So I think just a little common sense. And I tell patients, if you're completely risk averse, if you don't ever want to take any chance, then don't do it. But if you're not, and if you think you want to be able to do it, I don't think it's crazy. One technical question, does the ligament tension decide the spacing between the joints? Yes, that's how we decide. We can adjust that, but that's generally how we decide. Is it a good idea to strengthen the muscles? We've had numerous questions on this. And can the surgeon suggest what to do? I don't do that myself. I like people to see a therapist. In this day and age of cost effectiveness, that will often just take one visit, although some people prefer to actually do the exercise at the therapist and go back many times. Thank you for the information. I had a right knee replacement twice. First knee replacement was too large, feeling a bit frustrated with stiffness and only 90 degrees bend. Any chance of success with a third surgery? Is 3 times a charm? Couple things about this question. Thank you very much for the question, because it brings up a number of points. Point one, Is there a chance of success with a third surgery? Yes, but there's also a significant chance with a third surgery of being worse. So I would be very cautious. Have I ever done more than 3 surgeries for a joint replacement? Many times, for fractures, for people who've had knees for years where they've worn out. But the story that you present does not really tend to be the patients that have the highest amount of success. And like I say, a significant percent could be worse. So it's not, I see a patient every day in my office who has an unsuccessful knee joint replacement. I work in the same community for 35 years, and I feel the obligation to see at least those patients in my community. And quite often I have to say exactly this to them, that it looks pretty good. I don't see any major problems. If we go in there, I would say the chances of being better are equal to the chances of being worse. One thing, it's very easy for a surgeon to say that a knee replacement is too large. I hear that quite often in third and fourth opinions. And the patient will say, well, I went to see this other doctor. He or she said my knee was put in and was too large. Under most circumstances, that's not a clear indication for repeat surgery. In the old days, many years ago, we had many fewer sizes, and the success rate from surgery was the same, even in spite of having fewer sizes. Now, that's not totally valid because people are more demanding now, but overall, the patient satisfaction hasn't changed in 30 or 40 years. Let me see what else we can do. In the last couple minutes, we'll take just a couple more. How often should a patient have a follow-up examination with their surgeon? Most surgeons will see you within a few weeks of the surgery to make sure you're healing, and then within a couple of months of the surgery to see how you ultimately did. Then there's a lot of controversy. Some say, call me when you're doing, if you're having any problems. I tend to like to see my patients back after a year just to make sure that they're on the right track. A lot of times it's a good opportunity to answer questions. And a lot of times I tell them to come back every 4 or 5 years just to monitor. I would say a lot of patients don't make it to those later appointments, and they'll come in if they're having a problem. Controversial area. What results should be expected regarding range of motion, target, bend in the knee? It depends upon where you're starting. A patient who's very flexible tends to have good flexibility, and they tend to have a better bend. Patients who start out very stiff, we may be able to improve some, but it's hard to improve that too much. Let me just see if there's any other questions of general interest that we could maybe cover. So my question is, when will you be retiring? I have no plans to retire soon, but as the years go by, I think every surgeon looks at that. So, and then the last question is, you mentioned the cost many times. For those on Medicare, is a knee replacement fully covered either way? No, I mean, Medicare covers a percentage, and then a lot of patients have secondary insurance to try to cover the remainder. And so in the state of Pennsylvania, it usually is pretty effective in terms of coverage because most surgeons here take it. There are other places where surgeons don't accept Medicare, and they ask the surgeons to pay in cash, for good or for bad. So that doesn't happen very much here. But I think that's that it's always a good question to ask, so you don't have any surprises. There's been a lot of actually legislative discussion and a lot of legislation recently with a focus on dealing with these later rejections and trying not to surprise the patients or their care team down the road, because it can be very difficult to predict sometimes. So anyway, so I'm going to finish up and then turn this over to Natalie. But number one, I'd like to thank everybody for listening. We had a great amount of participation. It's always a very interesting topic. Please contact us at Rothman or Jefferson if there are other topics that you'd like to hear about, because we have tremendous surgical abilities. And also we have our non-surgeons who can help us out in so many different ways in orthopedics or in any other area. And we're very proud of who we are. And we're going to try to be out there with you as much as we can to try to provide you with the best outcomes in every way we can. And all of our surgeons feel that way. And we're just so gratified to be a part of our respective communities. So with that, I'll turn it over to Natalie to sum up.
Thank you, Dr. Starr. And thank you everyone for joining us this evening. Thank you for all of your questions. If we did not get to your question, apologize. I know Dr. Starr did try to get to most of them. If you do have any questions or any concerns, want to make an appointment with Dr. Starr or any of our physicians, you all have my email address. Feel free to contact me directly. We did record this presentation and we'll be sending it out to everyone who registered. So look for that in your email early next week. Thank you, Dr. Starr. Great presentation. And again, thanks everyone for hopping on here tonight with us. Have a great night, everybody.
Good night, everyone.